Cool. Thanks for having me, everyone. I apologize. Um, Part of COVID, I've been at home and I decided to grow a beard and I didn't realize it. But when we recorded that, it was clear this mustache is incredibly itchy and I just started grabbing my face over and over again. So I apologize for doing that. I'm going to try to go back into some of the questions that were posted, but feel free to post some other questions. There weren't a ton of actual questions posted, but please, by all means. There was a really interesting comment, sort of slash question that I'll raise, and it was, let's see, 4:15. I am often present during visits and consults with the physician for my deaf father who uses an iPhone with dictation app to aid in communication. Consequently, these visits seem to take twice as long as allotted. And then it looks like Medicare is billing for a long appointment. And I think this is a huge issue actually here that is not getting raised. And we tried to bring this up in our study, our claim study, where we were looking at hundreds of thousands of people at that point and seeing what happened over time. And adults with hearing loss are spending more time in healthcare visits. We looked at hospital length of stay, but we actually also looked at outpatient visits. And there was so much data, we didn't even publish it all. And outpatient visits are also longer, and they occur more often. So I think there's a huge burden happening here, and Medicare is actually sort of billing for it when my personal take on this is it's very much an equity issue, and this kind of research that we're showing should be used in in this case, to CMS or in Congress to actually remove that, because it's sort of not fair. If you need more time with your visit because there's any communication issue to make sure that you're receiving optimal care, it's not the fault of the individual. They shouldn't be incurring a higher cost. Again, this is sort of this inequality that adults with hearing loss are taking a higher burden of care than those without. There was one that I really liked about what, I can't find it again exactly, but essentially it was something along the lines of, what are medical schools doing to address this? And the short answer is medical schools do not think about this issue, which is really unfortunate. When I was finishing up my training, I was at Georgetown University Hospital, and all med students came over and spent some time in audiology, which is a different model that does not happen everywhere. And that gave us a chance to actually sit and talk with them about these issues. So we actually had a chance in that setting to educate med students. But the issue with that model is that you're placing the onus of educating med students on, well, just, we'll send them over to audiology and they'll learn all they need to learn about hearing loss. And I don't think that that's a very sustainable model. And I don't think that that's really fair either. I think that in general, med students need to learn more about communication across the board and about the sensory loss issues that may hamper communication and hamper medical understanding. Looking for others that were good ones. Talk about the challenges. So here's a question. Talk about the challenges for caregivers assisting older adults in telemedicine visits. This is, actually, I saw a lot of questions about this. And, I formulated this talk before COVID, and also I made a conscious decision not to go into what's going on really right now with this, because that's not where our research was. But this is so timely. We actually had a piece just come out in the Journal of the American Geriatric Society on telemedicine and communication in the hospital right now, and how we already know from our previous research that adults with hearing loss are bearing an unequal burden of healthcare, and it's a potential barrier of communication. And now we're throwing masks on people. Just today, a colleague of mine was calling me and talking to me about the noise in the hospital because we're using these airflow systems that are incredibly noisy. And on the telemedicine side, we basically seem to have people, not thinking about maximizing telemedicine by addressing sensory loss. We're sort of just treating it like a regular visit without much consideration. And so, I'm happy to say at Hopkins, we are starting to think this, where we're trying to push more and more on captioning systems, live captioning being the standard. There's no option for it. It happens all the time. And we're pushing for more face-to-face communication. And when physicians communicate with their patients, if they're in a COVID unit, for example, you have to wear the N95, which is it's never going to have a clear front to it. It's impossible to make an N95 that way. But some of you have actually mentioned in the comments the clear mask, which are those surgical masks that are clear. And those can be used outside of COVID units or in the hallways, outside of patient rooms. And we've had a lot of discussions, my colleagues and I, with actually using video conferencing as a method where that way, even if the physician or nurse are on the floor, they can wear the clear mask and then they can communicate into the room with their patients. And it's still video conferencing, but it's still better than that N95 mask, which takes up so much space, dampens sound, and doesn't allow for any visualization. Let's see. There was a question too, and I can't find it. Somebody brought up something about HIPAA and issues of self-identification, and I think that's a really good point. And I will say, in our study, we put hearing into. So I assume you're talking about like a labeling issue of like labeling people with hearing loss in the hospital and like saying hearing loss patient. And we've taken that out of our model completely. We had a long conversation with the ADA compliance office as well as several HIPAA officers. And essentially in the end, what we found was that hearing loss very much can be a part of the admissions process, asking about hearing loss and asking about understanding information. What we don't want to do though, and unfortunately, to be honest with you, what was happening was that, staff at the hospital were basically throwing like a Post-it note on a door saying something to the extent of, I can't hear you, speak louder, patient has hearing loss or something like that. So our signage takes the words hearing out of it completely, and we just focus on communication. And it does have the connotation from the education side that it reminds people of hearing loss, but we don't actually label anyone with something like saying something about their personal health. Instead, we use these sort of generic, like, remember, best practice communication is a big deal. And we don't let those signs sit on the wall. We take those signs and they only go up when a patient has identified hearing loss or mild or moderate hearing loss, or they're using a device, or they have hearing aids. That's the only time those signs actually go up to sort of remind you. They are going up quite often. The other thing I noticed about in the comments, somebody said those signs should go over the patient's head. Absolutely, they do. I can't tell you how hard it was to get that to happen. It seems several people who are commenting work in hospitals. And so, there are like these aesthetics committees that quite literally don't allow certain posters on walls. They don't allow things on in certain areas, different colors. We had to fight really hard to get something that was a bold color with bold language, and it was allowed to go above the patient's bed, so above their head. So that way the physicians, when they walked in the room, were forced to notice it. It didn't just stand on the outside. Let's see. Why is it impossible? Yeah, N95 mask. Sorry, it's the materials that make up the N95 mask. So an N95 mask is a very intense filtration mask versus the regular surgical masks that we often think of. Yeah, so there's a great question here. Some consumers are strong at advocating. And I saw this actually, I should address this. I saw a theme of some comments about that. Advocacy, please don't misinterpret this study as saying that we shouldn't advocate. Self-advocacy is incredibly important. So in my, the whole reason I'm in this area of research is on my father's side of the family, hearing loss runs in our family, and congenital hearing loss. And advocacy, without it, I can tell you from the personal experiences with my family, it would be impossible. You can only, you can't always have somebody there to sort of be your advocate. There is a self-advocacy aspect, and it's so important. But what I was making the point is that the hospitals need to recognize that not everybody is a strong self-advocate and not everybody is trained that way. And some people don't even recognize their hearing loss. And healthcare systems need to start recognizing this as a vital part of the process. And so the question is, do we think we can move the needle? And I absolutely do. And I'll be honest with you, this is a very cynical way of thinking, but what we're targeting with our future studies is whether or not we reduce healthcare costs and reduce length of stay by improving communication. And, unfortunately, that's the sort of magic potion that we'll be able to present to hospitals and say, look, if you address hearing loss and make care better for adults with hearing loss and improve communication, you actually save money in the long run. That is a powerful tool in the sort of argument's sake. And I hate that it is that way, because if it were up to me, I think that we should just be doing this because it's the right thing to do. But the money side helps. I'm not sure how much I went into it, but satisfaction is an incredibly important metric. So the Affordable Care Act added an aspect to Medicare where Medicare patients that stay in a hospital, about 20% of them will receive a satisfaction survey with that hospital. And some of the questions on that survey are communication based. And those surveys are aggregated for each hospital and then compared to the hospitals in their region. And it actually sets hospitals up for a different reimbursement tier. And so what that means is that there's an incentive to keep your patients as satisfied as possible, to make sure you're in the top reimbursement tier, so you can make more money. And for healthcare systems, and I'm sure many are aware, it's becoming more and more rare to have a standalone hospital. Most hospitals are in these big healthcare systems with multiple hospitals and multiple facilities. And so those systems, there's a huge incentive for them to improve their satisfaction. And so if they see that a program that sustainably addresses hearing loss to improve communication, improve satisfaction, it means, again, it hits that bottom dollar sign for them. And those, unfortunately, that's sort of what moves healthcare in this time. Can we get a copy? Yeah, the signs, you can definitely get a copy of the signs. We are putting them on JHU Solutions. I don't think they're definitely not up yet, but maybe I'll actually let some folks at HLAA know as soon as those are available. So you can we're going to put the high res image so you can download them and put them up how you'd like. Augmented reality should open up and improve communication. 100% agree. I've seen so many people talking about in this that the pocket talker and the hearing aid and regular amplification are not the end all be all of communication. I absolutely agree. I think that we need to think more broadly, and part of this is Medicare needs to cover things like oral rehabilitation sessions to make sure that we're talking more about like the communication strategies, and then thinking outside the box of, hearing aids are not the only thing. There's assistive listening devices. There are things like augmented reality that we could be using in the hospital, be using for patients, we could be using for telehealth visits. I think there's so much more we can be doing there. Will you take their study to the National Hospital Association? So yeah, actually, I saw somebody comment that I shouldn't be telling you this stuff. You already know this as HLAA members, and I absolutely agree with you. I'm presenting this to kind of share our work and hopefully get some people on the side of thinking about sustainable action. But the vast majority of my presentations of this work are to hospitals, hospital associations, congressional offices we've made this presentation to before, including working with the Congressional Budget Office before, as well as just physician groups. So I generally actually am targeting all of this work towards that audience because I think they're the ones that of the minds that we need to change. So somebody asked again about the N95 mask and elaborating on it. It's you know, I'm not an engineer, I'm not like a materials engineer, but you're looking at more layers of material than just one, you know, clear, like a surgical mask does not have that airtight suction and it only has like one layer of material. And so you end up with the ability to make that clear. N95 masks are much more in depth and there's multiple layers going on. So you'd have to get a materials engineer here to describe it, you know, completely. But as far as I know from my colleagues and from working with the biomedical engineering department at Hopkins, there's no way to make a clear N95. Let's see. Yes, somebody pointed out as an audiologist, they can't be reimbursed for provision of oral rehabilitation services. That's exactly what I'm saying, is that I think that Medicare needs to provide those oral rehabilitation services and cover them. I think that we often, you know, right now Medicare doesn't cover anything. So let's face it, there's that issue. But then we get lost in the idea of just covering the hearing aid. And I think we need to be more broad than that. I think there's a bigger fight to happen to cover all aspects of care so that it's not just one option. There's multiple options out there, and there's a nice pyramid that we can go down to accommodate everybody's different needs. That's a great point. What is my next step? So my next step, my next step is taking the work we've done building a feasibility trial, and we're doing a cluster clinical trial. So it's a clinical trial using clustered floors, pre and post design, so we can have hard data to actually show the effect. So right now we have a lot of secondary analysis studies that are epidemiologic in nature. And now we're moving to clinical trials so we can give a very definitive answer. Does this make a difference or not? And I'm fairly certain it does. You know, we've been doing this enough that we have pretty good hints that it will make a difference on the outcomes that matter to hospitals. You know, aside from sort of regularly advocating on in congressional settings, that is for me the primary next step, is getting science to support that. And like I said, you know, the National Institute on Aging have graciously funded my Career Development Award, which then funds this study and giving us this sort of more definitive work done. The amplifier that we mentioned, yeah, we use the super ear. For us in performance purposes, it's been very similar to the Pocket Talker. It's a great device. It's much cheaper than the Pocket Talker. The Pocket Talker is a fantastic device, though. You know, I'm not knocking one or the other as far as their performance. I'm just literally putting the price tag out there, and that's sort of what matters to us. And you know, we buy them in bulk. We buy, you know, hundreds at a time, and that allows us to give them to patients to take home and keep. Which actually, you know, I don't go into it because we were never really set up to capture that. But in our study, we actually had, I think, 7 people that we gave a super ear to come back to the hospital, and all but one of them brought it back. And their comments were basically along the lines of, nobody had ever really addressed hearing with me before. They did not have hearing aids. They had not gone to an audiologist before. Nobody had ever even like put the idea in their mind. And when we gave them something, they basically said, this is very helpful, and they were using it in their everyday life as well. Those pocket talkers and super ears, they're sort of bulky. They're not great for everyday life, but they were using them when watching TV, talking with family members in stationary settings. That sort of actually was a tipping point for me, in that programs that are sustainable and are built into the infrastructure that provide a device like this are also sort of an entry point to hearing care. So sort of a vital aspect to studies like this are that we also need to think about what's the link to helping people with their next steps. And not pandering to this community, one of those next steps actually that I think is the primary next step is linking people to their local HLAA chapter, because I think that is a stronger sort of community building connection and understanding connection than sending people straight to audiology always. If we send everybody straight to audiology, which, don't get me wrong, I am an audiologist. I think audiology is fantastic. We're just going to be making a lot of referrals that might be sort of empty referrals. So I sort of think we need like both. We need sort of a next point system where people can sort of, have multiple options of what they might do next. Caption telephones for inpatients, 1000% agree with you. Caption telephones are great. We have those on our list of, I'll call it like a list of demands that we make with the hospital. We ask for caption telephones, and we also ask for live captioning programs on all of our computer tablets that are provided to patients and physicians, so that way we can maximize communication in those areas. Yeah, that's a great point. Somebody's bringing up that healthcare providers could sell PSAPs, and that's a fantastic point. I know that some of his colleagues, or maybe actually he presented, Kevin Frank from Massachusetts General Hospital, Mass Pioneer actually, and Harvard. He is a leader in this area, I think, of trying to integrate sort of different over-the-counter, direct-to-consumer options, currently PSAPs, to be sold to patients in different areas. And so I think he's a great person and a great resource for that with his team. Yeah, somebody brought up the captioning on tablets. Google has a pretty strong live caption program, and it can be used on tablets to capture things live. And we actually recommend that as standard, as not even just as like a hearing loss thing, but just a standard protocol in the hospital to be doing that, so that we have that sort of live caption ability to reinforce things. If somebody needs to read, I fully admit to being somebody that reads captions. I'm somebody who watches TV with captions. I don't actually have hearing loss though, so it's just something I find beneficial. I did grow up around people with hearing loss though, which sort of reinforces that, introduces you to it. Yeah, a lot of people are talking about the clear masks still. Clear masks, fantastic. It is very important that it's not that the user who need it, is not the person who has hearing loss who might need it. It is that the physicians need to wear them, and the nurses, as well as other allied health providers. Somebody brought up, yes, the Google is for Android tablets. I'm not sure, I can't speak for all healthcare systems, but most that are delivering tablets throughout their system are using an Android tablet platform because the iPad is more expensive. Those that are using the iPad, there is sort of an equivalent live caption program that they're good to use too. We're using Android, which is why we're using the Google program. Otter, yeah, Otter, Live Transcribe, all great. Yep. Yep. somebody's bringing up about the ADA hospital coordinator to be a mediator. Absolutely. I think my personal take in my experience in large healthcare systems that I've worked in, the ADA hospital coordinators are so overburdened and so overworked, and we need a bigger office over there. And I actually hope that as part of our research and us presenting this in good forums, I'm hoping that this is something that, is also a part of this, that we're sort of expanding some of our allocated funding for the ADA office, because they do support better care, and better care leads to better healthcare outcomes, which in the long run, more healthy people actually lead to less expenses incurred by hospitals and by insurers. I see a comment about questions getting deleted. I don't know. I'm not sure if anything's being deleted. Maybe the system is not picking them up. Feel free to send it again, and I'm happy to try to answer. How can hospitals eliminate the fear of losing hearing aids? Man, I love this comment because I don't know. I wish there, if anybody, I think this is an area that's ripe for innovation. One of the problems is that right now, this is actually a direct comment from a focus group we held with nurses in a hospital system. They actually said, when we asked them about hearing aids, they were like, well, yeah, we ask about hearing aids and then we put them in a drawer because we don't want to lose them. And so there's this catch-22 of, when the hospitals do think about hearing aids, they become so afraid of losing them and so afraid of getting sued that they're not giving them to their patients to wear, despite those being vital to communication for somebody that uses their hearing aids on a regular basis. The flip side then is that hospitals don't think about them at all, and they're not asking about them. They're not encouraging people to bring them or anything. So it's really, really a difficult, I think, situation for both sides. A container may help prevent losing them, but again, like, there needs to be some sort of protocol in place to make sure people are then wearing them and using them, and we're not just taking them from people, putting them in a container, and then hiding them. And when I say hiding, I sort of mean storing them. Now that's a good point. Somebody brought up hospitals with assigning a wristband to people with hearing loss, same as you would do for a falls hazard. I think that's maybe a personal choice. I've never. I always struggle with the idea of wristbands. I sort of struggle with the idea in general of labeling, but it's not that we're labeling on purpose. It's that, we're doing it for healthcare purposes. And so I totally agree with this. For me, the way I think about this is, the reason we created our signs was to a certain extent, bring to the forefront of people's minds that hearing loss is an issue for this patient. It's potentially an issue. It's something they identified. But there's nothing on the signs that say, like, this patient has hearing loss. We're really targeting our providers on communication instead of saying, like, just a label, like that. So I fully agree with the concept of it. I think it's a great idea. I think that it has to be done thoughtfully, and I think it's one of those things where we sort of need the input of stakeholders, in this case being patients with hearing loss, to see what they think is best for them as well. All right, so we are down to one last question. I'm just picking the last one I see here. Where are containers kept? I would want them attached to my arm. That's specifically for somebody, but I agree with that. I think that's a great point. I find that a lot of times, in my experience, when we do have hearing aids in our hospital that we ask about, and we put them in anything, we actually put them in drawers next to the patient's bedside, or across from their bed in the room, which again are not doing anything for the patient. All right, I think that is all we have for questions. As I've always said, for anything with HLAA, if I can be of help, please feel free to send me an email or something like that. Happy to try to correspond and help. My email It's probably somewhere in this, but and it's definitely public if you Google my name, so I'm happy to give it out. It's NREED 9 at jhmi.edu. That's JHMI. So sorry, that's just me with a middle Atlantic accent. Thank you, everyone.